Good afternoon, everybody. I have been given the task to speak on antimicrobials in renal impairment. So just to recapitulate, this is all antibiotics and how different antibiotics works as an antibacteriostatic or bactericidals. So you have different mechanisms. Just to remember how these antibiotics works on. Like the sum of the antibiotics works on cell wall synthesis inhibitors, some are cell membrane, some folate synthetase inhibitors, protein synthesis inhibitors, some are working on the 50S ribosomes and some on 30S and fluoroquinolones. So these are the different groups of the antibiotics. All together you have the 6 different kind of the classes of antibiotics. So, but among this class of the antibiotics, it is usually easy to remember that which class of the antibiotics should be modified in which way, because individual antibiotics is very difficult to remember. So coming to the renal impairment, we all understand from our MBBS days, serum creatinine value is not the direct reflection of the impairment in the GFR or decline in the GFR. Usually the serum creatinine go up only when you have more than 50% decline in your GFR. Otherwise, serum creatinine value does not give direct reflection of the kidney functions or nephron functions. So that we must remember. So this is the reason why the pupils advocate for using some of the creatinine clearance formula to assess the real functions of the kidney. What is actually the creatinine clearance value? So there are different methods of the creatinine clearance. One we might remembered from the physiology book that GFR can be calculated easily with U into V by P. U means urinary creatinine. If you are able to estimate the urinary creatinine of the 24-hour collections, then divide it by the urinary volume and multiply by plasma creatinine value. That gives you, and that is the one of the most accurate. If your collection is accurate, that will give a very accurate formula for that patients about your GFR or creatinine clearance. Other important formula is Cockcroft-Gault equations. Particularly, Cockcroft-Gault's got so much of the importance because most of the drug leaflets, when you go back and read about the dose modifications, that is based on the Cockcroft-Gault formula equations. Very easy to remember, and that is all on this online. You can just do Google and you can see this Cockcroft-Gault equations. You have to fill up some of this like the age, body weight, serum creatinine value, and you will get this creatinine clearance value. And based on that creatinine clearance value or GFR, you can modify that particular drugs. And that is on, anybody has any confusion, any point of the time, do not hesitate to go back and read the leaflet of the drugs and how you can modify these drugs. Other important MDRD equations are there, CKD, EPI equations is now the most validated equations for getting the GFR. But for drug modification purposes, most of the pharma industry or most advocated is Cockcroft-Gault equations. So, but it is always easy, 140 minus age into weight divided by creatinine into 72. And if it is female, you can have the multiplication factors. But there is always a chance of overestimation or underestimation of the GFR. Just through this photographs, you can see what happens. Some of the drugs, some of the things are secreted again. Again, basically, creatinine is filtered through the blood and then it is excreted through the urine at the glomerulus level, but some amount of the serum creatinine is secreted into the tubules. So that gives some overestimations. More creatinine clearance than actually the filtration of the creatinine which is happening. Why I am talking here about some of the drugs inhibits this secretion of the serum creatinine into the tubule. So that will give the falsely high serum creatinine value. Like one of the important drugs that we sulfamethoxazole, cotrimoxazole, that contains trimethoprim, and cimetidine is no longer used now, but that also blocks the serum creatinine secretions. And once you are using this drug, serum creatinine value might be, creatinine clearance will go down and serum creatinine value may go up. So that sometimes you have to remember, sometimes it is so sensitive because in our renal transplant scenario, even more than 30% rise in the serum creatinine from the baseline, we think that is important for us and we should intervene. So whenever there is some fluctuations, so once you add on this Bactrim DS or trimethoprim, you must remember that this little rise might be because of this trimethoprim. And then it also depends on the muscle mass. Actually, creatine is formed from the creatine that is found in the muscles. If someone has a very low muscle mass, it is possible that the serum creatine value would be less. So sometimes it gives a different value. Some might be the meat eaters, and meat eaters might have the little bit higher serum creatine value. So that also gives. So there are multiple things which we should keep in mind when you see the patient clinically. So now coming to the pharmacodynamic parameters, these curves you might remember from our pharmacology days that whenever we give the drugs, there would be the peak, then gradually it comes down. And you have the area under curve of this peak, then this is the time line, and here is the concentration of the drugs. So peak is the parameter to optimize the concentration dependent antibiotics, and time is the parameter to optimize the time dependent antibiotics. So with this, you might remember there are two kinds of antibiotics only. One acts depending upon their concentration value. Higher the concentration, better the effect, better the bactericidal effect, better the bacteriostatic effect. One is the time dependent. So longer the period of the time the drugs would be in contact with this bacteria, there would be the better effect. Two important terms is one is MIC or MBC. MIC is minimum inhibitory concentration, is the lowest concentration of an antibiotic that inhibits the growth of a given strain of the bacteria. And minimum bactericidal concentration is the minimum concentration of an antimicrobial drug, that is bactericidal. Here from these photographs, you can see there are some organisms here at different concentration. It has been incubated. Here we can see there is no organisms here, no red colors. So this is the minimum inhibitory concentration is 4 microgram per ml. But what is MBC, bactericidal? What we can see on this plate, here there is some static effect, there is no further growth of the bacteria, but here is the concentration where bactericidal effect is there. So it is different. MIC and MBC are different. And we must always remember, many times we see the MIC value of the many of the drugs, and you might see all drugs are resistant. So out of which all resistant drugs, which drugs we should choose to give for that infection, that becomes important to take the clinical decision. So you have to see the minimum concentration, MIC. If the MIC of the drug which is the least, that antibiotic we should choose for giving out of all that resistant bacteria. So it is possible that that drug would be the most effective drug. So that we should remember. Sometimes it helps out in understanding of this MIC and MBC values. So what are the different antibiotics? What are the time dependent and what are the different, which are the concentration dependent antibiotics? Here we can see aminoglycosides is a concentration dependent antibiotics. It works as a bactericidal effect at the maximum concentration at the peak MIC. Penicillin, cephalosporin, carbapenem, and vancomycin are time dependent. Longer the duration of the drugs, better would be the effect. Macrolides, which again the time dependent antibiotics. Fluoroquinolones are concentration dependent antibiotics. So very limited data on cotrimoxazole. What we can see here, some of the antibiotics works in the best form when that is has the maximum concentration, like aminoglycoside and daptomycin. Some of the drugs depends on both time and concentration, like the vancomycin, fluoroquinolone, linezolid, and tigecycline. Here, this is dependent on the time and concentration both, and some of the drugs are time dependent, like the beta-lactamate or clindamycin. Why it is important? There are two important ways through which you can modify the drugs dosing. One is reducing the dose, other is the interval dosing. Time interval between the dosage remains same in reducing the dose criteria. Preferred for the beta-lactam antibiotics, penicillin, cephalosporin, and carbapenems. Macrolides like clarithromycin, erythromycin are safe, but only in certain adjusted doses reduce the clarithromycin to 50% of the usual dose in the pupils with the severe renal failure. If the patient is ESRD, dialysis dependent patients, then you have to reduce it by 50%. Interval dosing, keep the dose same, but lengthen the intervals of the doses. Interval dosing is usually preferred with the fluoroquinolones. Usually ciprofloxacin, levofloxacin, ofloxacin. The same thing is there in the at different places. You can see the two basic methods of adjusting doses, like the variable frequency regimes and variable dose regimes. So aminoglycosides, just coming to the gentamicins. In variable frequency dosing, gentamicin is usually given in loading dose of the 2 mg per kilogram body weight, followed by 1 mg per kilogram. And one formula was estimated that was taught during our MD time, that serum creatinine value into 8, that might be the usual intervals at which you can give this gentamicin. Similarly, in variable dose regimens, again loading dose remains the same, followed by 1 mg. Total dose divided by serum creatinine every 8 hours. The frequency you can, time interval you can keep the same. So there are different ways through which you can modify, but you should always remember that which drug has which kind of effect, which acts on the maximum peak. So here we can see aminoglycosides comes at the peak. Here you have this bactericidal effect of this antibiotic which comes down. Then after giving this concentrations go down, but there is some post-antibiotic effects. And this antibiotic here, it acts as a bacteriostatic effect. And some here we can have this at this level protects against the bacterial regrowth when the serum concentration falls below MIC. And some bacteria are more susceptible to intracellular killing or to phagocytosis by leukocytosis. So these effects continue. So many times aminoglycoside in patients of the renal failure, this is a nephrotoxic antibiotic that everyone understands, but we are the one who use very frequently these antibiotics. Adjusting the dose, reducing the toxicity. So once a day instead of 8 hourly or 6 hourly, it has equal effect in the patients on the dialysis. Or even sometimes we give every dialysis some of the doses, and it works equally good with the less toxicity. So dose adjustment should always keep in mind. So there are different ways that I have already talked about. So I'm just giving one example. Mr. JP, who was a 75-year-old gentleman, admitted to the renal unit with a long-standing history of type 2 diabetes and hypertension. Ideal body weight was 80 kg, serum creatinine 6. Now you have the GFR formula or creatinine clearance formula through Cockcroft-Gault equations. The GFR comes over 12 ml per minute, and the patient is falling into many places. Most of the drug leaflet you see normal renal function, mild, moderate, and severe. So this gentleman is falling into the moderate renal impairment. Mild with the GFR is 20 to 50, moderate is 10 to 20, and severe if less than 10 ml of the GFR. So what now you have to give the ciprofloxacin. That is one of the very commonly used OPD antibiotics. So ciprofloxacin we want to give. Renal dose impairment, degree of renal impairment is moderate. So you have to reduce the half the dose. If you are giving this too much high doses, normal doses is given, someone might, that lowers the seizure threshold, and some patients might throw seizures. So whenever we are prescribing these medicines, we must keep in mind about the side effect of the medicines also. So impact of the renal failure on pharmacokinetic of the drugs, that is also important. Renal failure has its own kind of the problem. The patient starts passing less amount of the urine, develops oliguria, the patients have the swelling of the body, and the volume of distributions of the drugs would be wide, will increase. Many times in renal failure, the efficacy of the enzymatic pathways are depressed, active and toxic metabolites accumulated, protein binding of the drugs are modified. If there is serum albumin level would be low, free drugs availability would be more. So sometimes the drug toxicity depends on this. So this is the complex scenario. What is the serum albumin value? What is the degree of the renal failure? How it is accumulated? So volume of the distribution, most of the times in renal failure patients who are passing less urine, most of the patients have the more volume of the distributions. So other scenario comes about the dialysis. When the patient becomes dialysis dependent, no urine output, then drug dosing during dialysis becomes another complex things. So that also depends on the characteristics of the drug and technical aspects of the dialysis system. So molecular weight becomes important. Volume distribution of the drug becomes important. And one of the important is the degree of the protein binding. Drugs which bonds to the protein, usually albumin, that does not filter out. In the conventional hemodialysis, albumin does not filter out. So that remains. So that drugs is not washed. Those, if you are given this intravenous medicines that go and bind to the protein or free albumin, then it remains in the body. It does not wash out. But some of the drugs like the aminoglycoside is water soluble. So even one single sessions of the dialysis will clear off all antibiotics. So in that group of the patient, if the patient is on aminoglycoside, amikacin kind of the drugs, that needs to be replaced after dialysis. So that we should always keep in the mind. What is the property of that drug? So antibiotics, particularly which one of the commonly used drugs are the cephalosporin group of the drugs. Renal excretion varies from 30% to 90%, and most of them are removed by dialysis. So usually prefer that whenever you dialyze the patient, replace some of the medicines, some of these antibiotics. Use the drugs thrice a week after hemodialysis or supplement after dialysis. Just giving one example. If suppose we have to give the vancomycin to the patients on the dialysis, what we do? We give one dose, 1 gram of the dose is given once a week in 5 to 7 days of the time. And that concentration of this vancomycin is not cleared through dialysis, conventional dialysis. So that remains in the adequate amount in concentration for a week time. So similar kind of the effect giving in the once a week of the vancomycin. Again now, so we must know about how to use these drugs in patients with renal failure. And one might have the idea that the vancomycin is very toxic medications, very much nephrotoxic medications, but we nephrologists use it very optimally, because many times these staph aureus infections, which are very much resistant MRSA kind of organisms, comes in, and you are forced to use this remains only the choice. And alone vancomycin does not cause that much of the toxicity. So when choosing the combination of the antibiotics, suppose gram-positive cover is given with this vancomycins, so and gram-negative cover you are giving this aminoglycoside, either gentamicin or amikacin, then the toxicity potential becomes 7 times higher. Alone nephrotoxicity of the vancomycin is very less. So combination we are choosing. So you have to choose some other cover if you want to give the gram-positive and gram-negative cover in combination. Other than amikacin, for gram-negative cover, you have to choose some other antibiotics. So drug supplementations, whatever the drugs is removed through the dialysis, we must remember whether this drugs needs to be replaced post-dialysis. One of the important area is our peritoneal dialysis, where the pharmacokinetic of the drugs totally change. Many of you might have seen the peritoneal dialysis patient, many might not have. So what do we do in peritoneal dialysis? This is the peritoneal dialysis fluid that goes into the abdominal cavity. We disconnect the patient for the 6 hours, they move around, and after 6 hours, that PD fluid is again taken back, that is effluent is taken back and it is replaced with a new fluid. So what happens? Suppose the patient develops peritonitis. That peritonitis is mostly the touch contaminations which happens. Peritonitis develops. Now we have to treat these infections. So what is better, whether to give this IV antibiotics or to give the intraperitoneal antibiotics? Because most of the times this is the touch contamination, intraperitoneal infections. So limited to peritonitis into abdominal cavity, to the peritoneum only. So better to give the intraperitoneal antibiotics, and that requires very less amount. So here what happens when you give this single dose, like the cefazolin is the one drug of choice given to this patient. Cefazolin has been given. This cefazolin we use once a day in 24 hours. What happens? This cefazolin has been given to intraperitoneally. Some amount is absorbed during this dwell time, and again it is secreted into the cavity, and that concentration remains there where you just continue working on for the next 24 hours. So mechanisms of the working of the drugs depends on what kind of the dialysis modality is there. Similarly, you can have this concentration, gentamicin pharmacokinetics. Again, this drug is absorbed, and after once you remove this drug, again this is secreted in the peritoneal cavity. Again, it works on. So both gram-positive and gram-negative cohort can be given. I am just giving examples of some of the drugs which are commonly used, like the piperacillin and piperacillin tazobactam, which is a commonly used antibiotics. What we can see, there is no change is required if your GFR is more than 40. If 20 to 40, make the dose half. Usually 4.5 grams is used 6 hourly. Make the dose 2.25 6 hourly, and then if less than 25, makes it 8 hourly. So this is the one drug. Rifampicin do not require any dose modifications. Similarly, you can see here cefoperazone usually do not require dose modification with the renal impairment. It is one of the commonly used antibiotic at our place. But you must remember, if there is hepatic disease and severe renal failure, the maximum recommended dose is 1 to 2 grams per day. So in that scenario, this is because I am giving emphasis because it is one of the commonly used drugs in our hospital. Similarly, ceftriaxones, no dose requirement, no dose adjustment in renal failure is required. Quinolones, usually more than 30 ml of the GFR, no change is required. Less than 30 ml, usually increase the interval of the dosings. So imipenem silestacin GNM is the one drug which is used to 250 to 1 gram 6 hourly based on the severity of the disease. So there is no requirement. What we can see here, no change if GFR is more than 70, 30 to 70 it is 8 hourly, then 20 to 30 it is 12 hourly, less than 20, half of the usual dose 12 hourly. Similarly, nitrofurantoin is the one drug which is many times this drug has been banned in between, but now again came into the market because of the increased sensitivity, very cheap drugs. But we must remember this drug should not be used because this cause irreversible axonal neuropathy if your GFR is low. So with whenever you have the serum creatinine renal impairment is there, use it very precautiously with precautions that it may lead to irreversible axonal neuropathy. This was the reason this drug has been banned. After banning for many years, again, this drug has been reported to be very sensitive to many of the bacteria, and that again came into the market. So amphotericin B is an antifungal antibiotic that we all understand. This is one conventional amphotericin is nephrotoxic, liposomal is usually relative to be safe. Not only this cause some nephrotoxicity and acute tubular injury, one of the many other mechanisms happens. Two important, one is electrolyte problem, that is hypokalemia. That is very commonly observed with the use of this amphotericin B. Other important is the metabolic acidosis. So normal anion gap metabolic acidosis used to happen. Whenever you are using these drugs, you must think of some renal impairment. If patient is developing hypokalemia, we should replace. If the patient is developing renal tubular acidosis, we should keep watch over his bicarbonate levels. So general rule for the preventions, be aware of the nephrotoxic potential of the septic drugs, specific drugs, identify patients at risk, be aware of the increased risk in the elderly, assess the benefit and risk ratio for treatment of the potentially nephrotoxic medications, avoid dehydration, beware of volume depletion, limit the dose, duration of treatment, adjust the dose based on the changes in GFR, avoid a combination of the potentially nephrotoxic medications. Thank you, ladies and gentlemen. Thank you. And these are some of online tools where you can click on and you can see the different dose modifications with the different modality, whether this is a CRRT that I have not touched purposely because of the lack of the time, CRRT, hemodialysis, peritoneal dialysis, or any drug modification with any degree of the renal fibrosis. Thank you, ladies and gentlemen.